Hi everyone, and welcome to our webinar, Public Health Genomics in Practice, State Strategies for Preventing Heritable Cancer and Cardiovascular Syndromes. This webinar is a joint presentation by the American Public Health Association Genomics Forum and Genetic Alliance. My name is James O'Leary. I'm the Chief Innovation Officer with Genetic Alliance, and I'll be your moderator today. This webinar will describe the role of public health agencies and their partners in implementing effective programs that address hereditary breast and ovarian cancer, Lynch Syndrome, and familial hypercholesterolemia at the population level. The experience of 5 states will be highlighted, including descriptions of their programs and funding. The agenda of the webinar is first we'll have an introduction by Dr. Muin Khoury, Director of the Office of Public Health Genomics at CDC. That will then be followed by a 15-minute video featuring the Michigan experience produced by Genetic Alliance and the Office of Public Health Genomics. And we're very happy to have Deb Duquette with us on the line, a genomics coordinator at the Michigan Department of Community Health, who will be available at the end of the call for Q&A. We'll then have a panel highlighting 4 state programs, which will feature Summer Cox, program coordinator from Oregon Genetics, Beverly Burke, coordinator in the Genomics Office of Connecticut Department of Health, Deb Lochner-Doyle, genetics coordinator at Washington State, and Dr. Jan Lowry, assistant professor at the University of Colorado School of Public Health. At the end of the webinar, we'll have Q&A, questions and comments. But as a reminder, all participants are muted. And what that means is that you can type in, actually throughout the conversation, your questions into the comments box on the right-hand side of your screen. We'll then compile those questions for the Q&A section of the presentation. And finally, as a reminder, this session is being recorded. Both the slides and the recording will be available on both the Genetic Alliance and the Genomics Forum websites for free after the call. So with that, let's get things started. Our first speaker of the day is Dr. Muin Khoury, and we'll put up his slides now and turn it over to him. Welcome, Muin.
All right. Thank you, James. I hope you can all hear me. It's truly exciting to be here today with you. And it's a good week to be in because it's National Public Health Week right now, and it illustrates what public health can do with healthcare to use the tools and the power of genomics to reduce the burden of cancer and heart disease. So just by the way of the background here, the CDC Office of Public Health Genomics has been in existence for 15 years at the CDC, whose mission is to provide timely and credible information for effective and responsible translation of genome-based discoveries into public health action. So we do 3 things: identify evidence-based applications, inform and communicate the stakeholders, both the CDC programs and care and public health agencies at the state level, and then help integrate ready applications into practice and programs. So last year has been really a good year in the field of public health genomics. We're always hearing about the excitement about whole genome sequencing and so on and so forth, but at the practical level, at the street level, sort of in terms of applications that actually save lives, there are 5 highlights that we recently highlighted on our website. The first one is that, of course, last year was the 50th anniversary of newborn screening, which is still the largest public health genetics program in the U.S. around the world. It also marked the 10th anniversary of the launch of the Surgeon General Family History Initiative with available family history tools that are for free, and Thanksgiving being Family History Day. We keep hearing about the emergence of whole genome sequencing in clinical practice, especially for the diagnosis of rare conditions. And very importantly in public health, pathogen whole genome sequencing is now begun to be used as a tool for tracking infectious disease outbreaks and early detection. There is a number of policy and legislative activities, the Affordable Care Act, FDA Action, Healthy People 2020, that seem to be increasingly using or sort of situating genomics in a good space in the healthcare system in the U.S. So for the last couple of years, we've been engaging with our stakeholders, and thank you Genetic Alliance, thank you the Genomics Forum, and many others in defining priorities for public health genomics in the next 5 years. We have a couple of reports that came out. The first one is the actual priorities, 2012-2017, available on the Genomic Forum website. And then following a year after that, new strategies for actions to save lives now in using genomics in public health settings beyond newborn screening. So an underpinning of the current activities in the Office of Public Health Genomics is the binning or classification of genomic applications into 3 tiers. The tier 1s that have been recommended by evidence-based groups based on systematic reviews. These are applications for which there are benefits that could be used today. Tier 2 are the ones that are coming along where the evidence is still a bit insufficient, but still could be used for informed decision making. And Tier 3 applications that are not ready for clinical use, but a lot of research is still needed. It's amazing to me that when we started this effort, the number of applications that are in Tier 1 keep increasing. And I would encourage our listeners to go to our website and check what's in different tiers. So for the purpose of the toolkit and the discussion today, we zeroed in a couple of years ago on 3 emerging Tier 1 genomic applications: hereditary breast and ovarian cancer due to BRCA mutations, hereditary non-polyposis colorectal cancer or Lynch syndrome, and familial hypercholesterolemia. So what's common between these 3 things? These are genetic conditions. They're inherited in autosomal dominant fashion. They all have adult onset. They're relatively common, collectively affecting 2 million people in the U.S. Most are not ascertained or managed well by our healthcare delivery system. And all of them have effective interventions that can actually reduce morbidity and mortality. And all of them have evidence-based recommendations, involve family history, and cascading interventions, can be integrated into public health programs such as cancer and heart disease programs at the CDC and state level. It could also serve as model for similar genomic applications in the future, and as such as only the tip of the iceberg. So for the last couple of years, we and our partners have been working on developing a toolkit that could be used by all 50 state health departments. The toolkit was launched a couple of weeks ago, and I would encourage you to check it out. It has general material as well as specific material to each one of these 3 conditions. And in conjunction with the toolkit, we launched last year a state program clickable map that you can check and see what's going on in each one of the 50 states vis-a-vis these 3 conditions. Now, both the toolkit and the map are moving targets. They are obviously outdated, and we depend on the information that's provided to us by the various state activities as well as what we find in the literature. So with that, I'm going to turn back the program to James to launch the video. Thank you very much all for being here today.
Excellent. Thank you so much, Dr. Corey. As a reminder, we'll be showing the video through the system, but if you do wind up having any technical difficulties, we did send out the link to go directly to the YouTube video in the chat box, but it should come up very clearly through your system. So with that, we'll get started.
One of the exciting reasons to be in public health is to make a difference in the life of people. Saving lives, preventing death, premature death, and genomics is allowing us to do a lot of this right now. The 2 conditions we're talking about, hereditary breast and ovarian cancer due to BRCA mutation and hereditary colorectal cancer or Lynch syndrome, illustrate what we can do from a public health perspective. There are more than 1 million people affected in the United States with one of these 2 conditions. We know that there are many affected people that are not being diagnosed.
Lynch syndrome is a hereditary genomic cancer syndrome that causes increased risk of colon, ovarian, and endometrial cancers, along with a few other gastric cancers. It's estimated that about 1 in every 30 colorectal cancers is related to Lynch syndrome.
Approximately 2 to 7% of all breast cancers and 10 to 15% of all ovarian cancers are related to mutations in the BRCA1 and 2 genes.
The good news is we now have these tests that are able to identify risk in people who have that risk, whether they had the test or not. The risk was there, and now you can know about it, act upon it, prolong your life, avoid a terrible outcome. That's good. That's what prevention is supposed to be all about. Prevention in the past hasn't had the opportunity to take advantage of this very specific, individualized digital information. This is personalized medicine actually becoming real and becoming available to many more people than could have been imagined a few years ago.
So the challenge is to find people and connect them with the right services.
Both of my sons were tested. One son did not have Lynch syndrome and one son did have Lynch syndrome.
My girls were never able to meet their grandmother, and my goal is to make it that no other kid loses their grandmother too soon, and that I get to see my grandchildren someday.
What is really needed is to engage families where these cancers run and to help give them the opportunity to identify that they're at high risk, but that there are actions they can take to greatly reduce their risk. And this can often reduce the fear, it can reduce the uncertainty, and also can have a remarkable impact on an entire family. So the Healthy People Goals play a key role in how the nation and especially the Department of Health and Human Services and the executive branch of the federal government, how we plan and set goals for public health for the nation.
They were started in 1979, but the Healthy People 2020 objectives marked the first time that cancer genomics was actually included.
So this is a real change from the traditional goals that we've had related to cancer, like those for reducing smoking or increasing colorectal cancer screening, for example. So the Healthy People Goals are a way to plan, to convene, to track our progress, and also for all of us to hold ourselves accountable for progress in cancer control, including in the genomics area.
The idea that there are currently genetic applications today that we can use to save lives and reduce the suffering from cancer is an idea whose time has come.
A big part of what CDC does is fund state health departments to address community health issues. The Michigan Department of Community Health has been really a flagship in addressing genomics applications into cancer prevention and control.
Thanks to many individuals within the state of Michigan, this issue of cancer genomics started to become a very important issue that emerged over 10 years ago. The Michigan Department of Community Health's mission is to protect, promote, and preserve the health and safety of people in the state of Michigan, with particular attention to those in vulnerable populations. This is especially important to our Michigan Department of Community Health Cancer Genomics program because we are working to reduce the number of deaths due to cancer at a young age, especially with appropriate use of cancer genomics applications. We hope that these steps will help other state health departments that are also considering addressing these Tier 1 applications, and these can serve as a roadmap perhaps for other state health departments. Over 10 years ago, one of the very first steps that we took at the Michigan Department of Community Health was to actually look at our existing cancer registry data to figure out the number of cases that could be at high risk for hereditary cancers. And we were quite surprised to find that there were over 15,000 cases per year in our state of Michigan that were potentially at high hereditary cancer risk and should be looked at more carefully. Those numbers drove us to action, further access, greater awareness, important policies in place to address the needs of those potentially 15,000 individuals per year.
Their goal is really to implement identification through family history and other mechanisms, and then management of people at increased risk for hereditary cancers.
Identifying individuals at risk who can benefit from early screening as well as risk-reducing strategies that can ultimately reduce morbidity and mortality in these individuals and their relatives.
Our job as health professionals and our job in public health is to help physicians identify these individuals and intervene early. And I think that working in partnership with state agencies, this is how we're actually going to be able to move the field forward.
While genomic applications might seem new, Many of the strategies and activities already used in state chronic disease prevention programs are applicable in genomics as well. For example, state cancer prevention and control programs can work with their cancer registries or their state comprehensive cancer control program to integrate genomics into their existing infrastructure. Partnering with existing programs to leverage resources and take advantage of existing infrastructure will make the integration of genomics applications more feasible and provide a greater public health impact.
Once the Michigan Department of Community Health looked at our existing data, we decided to bring together partners from across the state of Michigan to actually address this issue, and we developed something called the Michigan Cancer Genetics Alliance. The Michigan Cancer Genetics Alliance is comprised of clinicians, researchers, patient advocacy groups, as well as many other individuals that are interested in making sure that there's appropriate translation of cancer genomics.
I wanted to be able to network with other hospitals as well as universities who had instituted similar policies as we had done here at Karmanos in terms of universal screening. And there's now over 200 members worldwide of the Lynch Syndrome Screening Network. And ironically, it was the Michigan Department of Community Health that created the Lynch Syndrome Screening Network using some funds from the CDC. And the Michigan Cancer Genetics Alliance in turn is a member organization of the Michigan Cancer Consortium. And it's through that partnership that led to Michigan being one of the first states to have genomics as an entire goal amongst their state cancer genetics control program.
Any one individual does not know everything, and we cannot all reach everyone.
When it comes to partnership, I'd say don't be afraid to approach other people and other groups that you know are doing this type of work. Don't be afraid to get your program out there and really promote what you're doing. I've been amazed how many times different people will come to us and say, we really like what we're doing, we're interested in this, how can we work together?
Conducting surveillance either through the state cancer registry or through surveys like the Behavioral Risk Factor and Surveillance Survey not only gives programs the opportunity to understand the burden of disease in their state, but also gives them the chance to use that data to plan for the future and to track disease progress over time.
One of the things that the Michigan Department of Community Health has been doing since 2008 is actually providing information to health plan payers in our state of Michigan. We've been providing information about evidence-based guidelines for appropriate referrals for individuals at high risk for hereditary cancer syndromes.
So we've worked very closely with Michigan health plans over the past few years to try to get them to have policies in place. It's important to have those written policies in place so providers know what the coverage is for their patients, and in addition so that those tests actually get covered.
When you have a core set of guidelines or best practice, it's, shall we say, ready for implementation in a meaningful way.
The Pinnacle Awards added in an award specifically for health payers that would be in alignment with the task force guidelines. It was able to at least bring to the attention of other payers the value and importance of those guidelines and having a medical policy.
Every year when we present the Pinnacle Awards, we also acknowledge the plans that in the past year have developed policies that are consistent with the U.S. Preventative Services Task Force recommendations.
So one of the other things that we did is the state was really trying to promote the awareness of cancer genetics and genomics. We needed people to educate the healthcare providers in the state, the people in the Michigan Department of Community Health, but we also needed to educate the public. And so they tapped on the expertise that was within our group to go out and provide those educational services.
And since 2003, we have actually had a genomics educator on staff that has actually done many, many things to try to promote education, specifically about cancer genomics, to patients and providers. We've also partnered with many individuals within the Michigan Cancer Consortium to provide education to providers and patients. Data that was already provided to the state by local cancer registrars is actually reformatted in a way to highlight those cases that are at greatest risk for hereditary cancer syndromes. That information is then given back to those local cancer registrars, as well as key administrators within that hospital system, with educational materials explaining why those individuals are at high risk.
We created facility-specific reports that listed the cancers that each facility saw. That way they could identify the people and get back to them and maybe refer them onto genetic services or get them a better referral or a more appropriate care. An epidemiologist or a surveillance plan is important in any public health program. What we do is we analyze data and we identify what the need is in the state and where the need is the greatest.
We work together to determine what is being documented in the medical record, what kind of information can we gather currently, and how can we improve upon the information that is documented in the medical record.
They allow us to measure what needs to be done and where we're at in doing that work.
One of the main lessons I take away is that cancer control is a very large and all-encompassing area. Cancer is not just one disease, but many. And to address cancer control in a state and reduce the impact of cancer, including both the number of cases and death and suffering, you need to work together.
We began working with the MDCH here at Beaumont in 2008, so it's been a 5-year process, and 5 years ago, seeing the success and the progress that we've made has been astounding.
Well, family health history is really one of the best tools that we have to identify individuals that may be at an increased risk for developing cancer.
It's a scary prospect to think that you might carry a gene that increases your risk of cancer. But it's much better to find out ahead of time because there's so much that can be done now in terms of the early screening, detection, and management. We would hate for someone not to be able to take advantage of the medical interventions that truly can help save lives.
If you're aware and people know about the Lynch syndrome and it is more publicized, that people understand it, then it can help to save lives.
A lot of individuals, they're afraid to see a genetic counselor and they're afraid to have genetic testing. And I think part of that fear is they don't understand what genetic counselors do, that they're here to be an advocate for families and we're here to support them and provide them with information.
My son is 35 years old and he was treated and had the surgery like I had, so he's got many, many more years that he can live now.
And now we have groups and we have committees and we have counselors who help us know that it's not us, just us. We are a family doing this together.
The genomic revolution has now made it possible for genetic testing to reach the mainstream of clinical medicine, providing opportunities for individuals to learn about risks they would want to know about. Yet it is not just automatic that will happen overnight. It's going to take the full engagement of policymakers, healthcare providers, reimbursement agencies, insurance companies, and patients to take advantage of what should be a major step forward. We all have to work on this together.
At this point, I'm very excited to introduce our speakers. We really wanted to provide a range of different programs and also different funding levels across states to give you an idea of what you can do in your state to implement these important programs. So with that, I'm going to turn things over to Summer Cox from Oregon. Summer, are you on the phone?
I am. Thank you, James.
Thank you.
Good afternoon, everyone. I'm Summer Lee Cox from the Oregon Genetics Program of the Public Health Division within the Oregon Health Authority. Currently, our program is funded by the Division of Cancer Prevention and Control at the Centers for Disease Control and Prevention, and we are working on hereditary breast and ovarian cancer syndrome using surveillance, education, and policy interventions. Our surveillance activities help us identify the use and understanding of genetic information and applications in our state, as well as identify current gaps and opportunities for change. I'll talk more about these efforts in another slide. In our education efforts, we focus on healthcare providers, health insurance companies, and the public, including individuals with Ashkenazi Jewish ancestry, breast and ovarian cancer survivors, and others. We recently collaborated with the Oregon State Cancer Registry and sent educational letters to cancer survivors who met NCCN criteria for being referred to genetic services for hereditary breast and ovarian cancer syndrome. We also sent educational letters to the clinicians of the selected patients. And it was through this simultaneous dissemination that we were able to promote discussion of hereditary breast and ovarian cancer syndrome and genetic services among the patients and clinicians and build awareness on both sides. Our policy activities include working with health insurance companies to align coverage with evidence-based guidelines, working with the Oregon Medicaid's Health Evidence Review Commission to maintain coverage policies in line with guidelines, increase stakeholder knowledge about genetic counseling licensure issues, and including genetic information in the Oregon Comprehensive Cancer Control Plan. And for states who do not have genetic information integrated into their cancer plan, this is a great place to start, just as they mentioned in the video that we just saw. We've found that genetic and genomic literacy is an ongoing issue in our state and across the nation. And to help address this, the Michigan Department of Community Health, our program, the Georgia Department of Health, the National Coalition for Health Professional Education in Genetics, and the CDC Division of Cancer Prevention and Control collaborated to develop an educational module for primary care providers, including physicians, physician assistants, and nurse practitioners, called Hereditary Breast and Ovarian Cancer, Is Your Patient at High Risk? This module has 7 highlighted case studies, additional resources, and offers free CMEs through the American Medical Association. The module is being hosted by the Jackson Laboratory and is a great resource for any healthcare provider interested in improving their hereditary breast and ovarian cancer literacy. Surveillance is the foundation of our program, and this is a key area for states to begin their efforts. This very busy slide shows most of our surveillance activities and how they inform our understanding of genetic issues in Oregon. The cost of surveillance activities runs a very wide spectrum. Working with the cancer genetic clinics in our state to collect demographic and clinical data on patients being seen for HBOC reasons, for example, has been a rich source of information, but it's also been hugely resource intensive. While activities such as analyzing claims data or cancer registry data have been key to our messaging, are also much less resource intensive. Identifying what information is already available in our state has also helped us identify fellow public health programs and other agencies that share key goals with us and has led to very strong partnerships. The lack of genetic and genomic literacy is a significant barrier in improving access to genetic services. So efforts to continue building literacy are definitely needed. Collaboration and communication are key to increasing awareness of public health genomic issues. And as part of that, establishing partnerships is important, but not enough. We have had greater success when multiple partners can be brought together and we can all focus on an issue together, whether there's funding capacity, or creative thinking that is your limited resource of the moment. Including a diverse set of partners in the discussion really will help. What gets measured gets done. It sounds trite, but it really is true. Finding out where the unmet needs and data gaps are and where there is evidence of intervention needed is the place to start. And once you have baseline data, it can be used to focus your activities and then measure the impact of particular interventions and to reassess data over time. We've also used multiple data sources. Decisions are only as good as the data that we use, that we base them on, and data from multiple sources can give a much more accurate understanding of the situation. For example, we've used data from the Oregon State Cancer Registry, Oregon Census data, and information from the literature to estimate the prevalence of BRCA mutations in the Oregon adult population, the prevalence of BRCA mutations among Oregonians diagnosed with cancer, and the number of adult Oregonians diagnosed with cancer that may benefit from genetic services. In addition, Multiple and comprehensive approaches are almost always needed to get the job done. So solutions that are multi-pronged will more fully address the issues at hand. We are working with patients, providers, and health insurance companies to promote the use of evidence-based guidelines in referring to genetic services, with the goal of increasing the proportion of women with a family history of breast and/or ovarian cancer who receive genetic counseling. Thank you so much for your attention. Please don't hesitate to reach out.
Great. Thank you so much, Summer. Our next speaker is Beverly Burke from the Connecticut Department of Health.
Great. Thank you, James, and thanks for inviting our participation. I really think there's such great potential being presented here today, and I would like to share an approach that we took in Connecticut that we hope may benefit other states' efforts. By way of background, the Connecticut Department of Public Health has had a state plan for public health genomics since 2002, as well as our genomics office. And as part of our work, we have closely monitored research findings and innovative models such as Michigan's, shown in the video, in cancer genomics, due to the heavy burden of disease in our state. In 2009, Connecticut had the second highest rate of female breast cancer in the nation and sixth highest rate of ovarian and uterine cancers in the nation, with colorectal cancer being the second leading cause of cancer death in our state. So this burden of disease in Connecticut has driven our interest in promoting related evidence-based guidelines for 2 hereditary cancer syndromes. And I think it's important to mention that knowing and using such data, as the other speakers have mentioned, using such data really helped us articulate how important these efforts were, and really helped as we approached partners for them to coalesce around this issue and around the potential for beneficial impact. We took note of the new guidelines and recommendations for hereditary breast and ovarian cancer and Lynch syndrome, and correspondingly, as mentioned before, the new Healthy People 2020 objectives, which had introduced the new genomics topic areas. Here again, that helped highlight their importance to our overall public health mission. Our Connecticut response was a collaborative effort involving our DPH Genomics Office, the Connecticut Tumor Registry, the breast and cervical cancer and colorectal cancer programs, and hospital cancer registrars, with our goal to increase healthcare providers' awareness, knowledge, and adoption of the evidence-based recommendations, and ultimately leading to better health outcomes. So in 2011, we received a small award from the U.S. Department of Health and Human Services to implement our Healthy People 2020 Action Project, promoting the 2 evidence-based recommendations. So phase 1 of our project, including mailing a hospital-specific packet containing cancer registry data reports and accompanying educational materials to select staff at hospitals such as cancer boards, heads of oncology, radiology, and so on, at all Connecticut reporting hospitals, together with an invitation signed by our commissioner to receive a Grand Rounds training that was provided on their site by a cancer-certified genetic counselor on these hereditary cancers and the evidence-based practice recommendations. So the packet included the items that you see listed here, the hospital-specific data reports containing the multi-year Connecticut Tumor Registry data from their hospital on the number of diagnosed cancers potentially associated with these syndromes, copies of the recommendations themselves, and resource information, including a patient fact sheet on each syndrome, lists of cancer genetic counselors in our state, and the Grand Rounds invitations. We also recorded and posted one of these Grand Rounds sessions on our distance learning site. You see here the cover of the education packet, which is also posted on our website. This packet included the fact sheet that I mentioned and the corresponding patient information sheet on each syndrome that's available in English and in Spanish. And as I mentioned, each hospital was offered a Grand Rounds training on the prevention and early detection of these cancers and the appropriate use of genetic counseling services and tests. By the end of the funding period, we had delivered training to 70% of our reporting hospitals, which far exceeded our goals. And also importantly, a survey was administered at each of these presentations, with that data helping to identify for us ongoing areas of need and to inform our future activities. And the feedback indicated that nearly 90% of attendees reported an increased appreciation for the use of family health history as a result of that training. In phase 2, we expanded the efforts to include distribution to over 900 Connecticut physicians in obstetrics, gynecology, or gastroenterology who were sent the educational materials along with an HBOC and Lynch syndrome risk assessment decision support slide tool. And as well as a survey indicating or asking how they planned on using this information. So with regard to our next steps and anticipated next efforts in cancer genomics in Connecticut, you see them here. One of them being the updating and distribution of subsequent data reports and updating the resources on these hereditary cancers on a biannual basis, which is currently underway now. So thank you for your interest. Feel free to peruse these items on our website, and we hope you find this information useful. Thanks.
Great. Thank you so much, Bev. As a reminder to those listening, you can type in questions on the panel on the right-hand side of your screen, and we'll get to those at the end of all of our presentations. Our next speaker is Deborah Lochner-Doyle from Washington State.
Thanks, James, and thanks for the organizers for thinking of Washington. Washington has had a public health genetics program for many years, since 1991, but much of our emphasis has been focusing on making sure that all Washington residents have access to genetic services via regional genetic clinics, systems, et cetera. So it wasn't really until the Healthy People 2020 goals came out that we really started thinking more about some of these Tier 1 genomics issues, including hereditary breast ovarian cancer syndrome, Lynch syndrome, and familial hypercholesterolemia. So I want to share with you just a couple of projects that we've worked on, and I think that one of the reasons that Washington was asked to present is that unlike Connecticut or Michigan or Oregon or some of the other states that have dedicated public health genomics funding to address these Tier 1 issues, we don't have dedicated funding. We have resources, of course, that are based on what we've already had in place, but we have no special grant projects, et cetera. So it's, again, working with what we've got. So one of the projects that we have been involved with that we have actually concluded is we stopped and looked at the 9 largest insurance companies in our state, and via a web-based search as well as telephone interviews with the medical directors of these insurance plans, we compared their policies as they related to genetic counseling or genetic testing to see whether they would be aligned with the National Comprehensive Cancer Network or NCCN guidelines or U.S. Preventive Services Task Force guidelines. And very pleased to find out that indeed they all covered these services, although all but 2 of them had dedicated policies in place. More recently, I've been spending a lot of time thinking about familial hypercholesterolemia, and largely because, we didn't talk a lot about cascade screening, but one of the issues with these particular Tier 1 conditions is that once you identify the proband, you can obviously then go test family members, hopefully at a time when they are asymptomatic and can benefit from treatment, early treatment. But with familial hypercholesterolemia, unlike the cancers, it's very difficult to find the proband. In fact, some of the published reports suggest that in the United States, less than 25% or even less than 10% of individuals with FH are even diagnosed. So it makes it a little bit more difficult. And for that reason, I've been thinking a lot about how do we go about and identify these individuals affected with FH. I came up with this project that I'll describe here, and I apologize for the typo. That should say all 9 to 11-year-olds. My thought was that if we could, in fact, go to a health system that hopefully would have electronic health records, we can, in fact, pull all of the 9 to 11-year-olds to see if, in fact, they have a cholesterol screen on file. That is the American Academy of Pediatrics recommendation that all 9 to 11-year-olds have their cholesterol screened. And then, of course, if you identify children that have elevated cholesterol levels, obviously you'd want to treat them to get them into better cholesterol levels, but also evaluate them to see if they have xanthomas, as well as evaluate their families, their parents, to see if they have xanthomas. And that would be your indication for these kids that have very elevated cholesterol, that in fact they have FH. Those individuals I would then want to do genetic testing on and then potentially do cascade screening on family members. What I'd really like to do with this project is to pilot it. I'd like to work with the health economist to see the cost-benefit of identifying the probands as well as doing the cascade screening, and then long-term what the potential savings would be in terms of reducing morbidity and mortality. Obviously, what I'd hope to do is reduce congenital heart disease by identifying and treating individuals with hypercholesterolemia, irrespective of whether or not they have an FH diagnosis, through routine lipoprotein screening, and then, of course, reduce death and disability by identifying those individuals specifically that have FH. So again, we have no specific funding in Washington State. We do have some staff. They have myself, one other individual, and we do have a support staff who spends half of her time working with genetics as well as half of her time working with newborn hearing screening. Our staff are funded by state funds as well as maternal and child health block grant funds. So again, much of the work that I've described here has been based on what we've been able to do on our staff time. Next slide. So again, what we've learned with respect to the insurance payers, as I already mentioned, all of our payers in Washington do cover the services of genetic counseling as well as genetic testing. Most of them do require pre-authorization. All but 2 have specific written policies. And in those that do not have specific written policies, they do have coverage through what they call their medical necessity. And as far as the familial hypercholesterolemia, well, I have not identified a partner yet. I have shopped this idea around with group health, with multi-care, Geisinger, a couple other health systems, and I haven't found a partner yet, but I'm still very optimistic that I can find someone. This is a situation where actually having resources might have helped. I've identified some health economists at the University of Washington who are also very interested in trying to do this work and cost it out. Unfortunately, they're not willing to give me their time for free. So again, I'm still optimistic that we will find a partner. And as you've already heard throughout the presentations, that it really does take partners to get this work done. So with that, I will close and look forward to the questions.
Excellent. Thank you so much. Our final speaker for today is Dr. Jan Lowry from Colorado. Jan?
Thank you, James, and thank you for having me be a panelist today. So I'm a cancer epidemiologist from the Colorado School of Public Health, and today I'd like to share our experience with a project on which we collaborated with our state cancer registry. And this was a small pilot study funded by Mountain States Genetics Collaborative. So the purpose of our project was to increase awareness about hereditary colon cancer among both providers and their patients that are at risk using a central cancer registry. And the parallel goal was to assess the feasibility and acceptability of using the registry essentially to do direct-to-patient outreach, in particular about cancer and genetics, where we've had lots of experience using the registry to recruit patients for research studies, you really have never had the opportunity to test whether this would be a viable mechanism for doing public health work. So in order to identify our at-risk population, we applied the Bethesda criteria that we could to the registry data, which included colorectal cancer under the age of 50, multiple colorectal cancers or Lynch syndrome-related cancers within an individual, or colorectal cancer under the age of 60 with if the tumors had specific MSI histologies. Because the registry policy was we first have to obtain provider consent before contacting patients. We did so. We also saw this as an opportunity to do educational outreach to the providers as well. So when we contacted providers to obtain consent to contact their patients, we also sent them the same brochure that we had developed to send to their patients. Once we had consent from providers, we then mailed the patients the same brochure, which included general information about what is hereditary colon cancer, who's at risk, what do these families look like, and what is risk assessment. And we also provided patients with a resource directory with contact information of genetic counselors around the state of Colorado. At the time we initially contacted both providers and the patients, we sent them a survey, and we were also able to contact patients 4 months later. So busy slide, but this again provides an idea of the scope and the flow of our project. We were able to identify about 800 colorectal cancer cases at risk. This goes back about 5 years of cases within the registry. Those patients were associated with a little over 400 physicians who we contacted to obtain consent to contact. And you will see that we only had about 50% of the physicians respond, although most of those did give consent to contact patients. And this was because at the time the registry required active or written consent from the providers. They've now implemented new policy where we could have passive consent. So we were able at the end to identify or contact, if you will, 226 patients to whom we mailed the educational packet and initial survey, and then again we were able to follow up with patients 4 months later. So a couple of slides just demonstrating some of our findings. This slide presents results from the physician survey. As you can see, the majority of physicians thought that the information contained in the brochure was easy to understand. Most found that it would be useful to their patients. We asked the providers whether they thought the registry should do this. Should they do educational outreach about hereditary cancer to patients? And the vast majority, 90%, told us yes, that in fact this is something that the registry should do. And actually 60% of the physicians that said yes told us that it would actually be okay if the registry did so without obtaining their consent. So results from the initial patient survey. And again, the point of the initial survey really was to assess impact. Again, we had never tried this directly from a registry. So we're really interested in seeing what the patients, how they reacted to the materials that they were given. And what we found out was very promising. Most of the patients, 77%, told us that they were very happy to have received the information. Many had told us that they were interested in finding out a little bit more about hereditary cancer. Very few patients told us that the materials made them more concerned or worried. And importantly, for us and to the IRB, the State Cancer Registry, no one was really angry, which is really an important outcome for us. We similarly asked the patients whether they thought the registry, whether this was a good use of the registry, whether the registry should be sending this information out to individuals at risk. And similar to the providers, over 90% of the patients told us yes. What was interesting, though, because in contrast to the providers, most of the patients, although they thought that the registry should be doing this, they wanted their physician contacted prior to having them send the material. And as I said earlier, we were able to administer a follow-up survey 4 months after initial contact with patients. And this is where we were trying to assess the impact of the educational materials themselves. And we asked patients whether they had at least talked to someone about risk assessment since the time that they had been contacted initially. And although 60% said they had not, 40% said that they had. So 40% of the patients that we were able to contact said that they had spoken to either their doctor, a genetic counselor, a friend, or family about cancer risk assessment. We also asked patients at this time whether in the past 4 months they had had a cancer risk assessment or whether they had intended to have one in the near future. And we found that about a third of the patients, in fact, said that they had or intended to, and 20% were still not sure. So in summary, we found that this rather simple outreach was well received both by the providers and the patients. The simple meal-based approach was at least somewhat effective in getting people to talk about risk assessment. So we feel that using the Cancer Registry for outreach about hereditary cancer is a viable approach, as others have spoke about today. For this project, it was, of course, critical to have registry support. We really couldn't have done this without the support of the director of our Cancer Registry. They were a little worried at first whether this would be something that the patients, upon receiving the information would be upset about, but our director was a champion for us in getting us through the IRB at the registry. And we also think it's critical to have genetic counselors involved. We did provide a toll-free line for patients to call should they have questions about the information that they received. And although very few patients took us up on the offer, we feel it's important to have counselors in place should anyone have specific questions regarding their risk. The challenge, of course, moving forward is one that we all face is funding and finding a way to sustain this activity by somehow incorporating this into the normal registry operations while minimizing cost and staff time. As far as next steps for us, one way to sort of expand reach, if you will, if we were to move on and do this on a more regular basis would be the inclusion of the MSI or IHC results, which are now, our registry now collects in response to universal testing here in Colorado. One could also apply a similar strategy for identifying women at high risk for hereditary breast and ovarian cancer. And something that we're thinking about here is whether we could actually use this same strategy, or can we use this strategy to reach family members at risk. So with that, I welcome any questions in the question-answer period, but I'll send it back to James.
Great, thank you so much. If people have any questions, a reminder you can type them in on the right-hand side. One question to start off with for Dr. Lowry is, for the colorectal cancer survey in Colorado, was this done via email or regular mail? Was there any thought of doing this via social media outlets or tools?
We did ours strictly by mail. Our registry does not routinely collect email addresses on the patients.
Okay. And also another question, can you describe the passive consent of providers in a little bit more detail?
Sure. So passive consent would be we would send the provider a note, a letter saying we'd like to contact your patient and send this information. If we don't hear from you in the next 3 weeks, we're going to assume that it's okay. So it doesn't require a written signed document sent back to the registry.
Okay, excellent. I have a question for Deborah Duquette, which is when the video talked a lot about champions and building partnerships. What are some of the ways that you would recommend that people build support within their state for these types of initiatives?
Hi, James. This is Deb from Michigan Department of Community Health. And I would say one of the first steps to do would be to meet with your state health department program folks, so to meet with your state cancer registry folks, to meet with your comprehensive cancer folks, or if you're thinking about doing something with familial hypercholesterolemia, with the cardiovascular folks or Medicaid folks. And then I would also strongly recommend, as I think that Summer said as well, to definitely get involved when there's needs assessments going on at the state public health level and state plan and strategic plan going on, because that's a way that you're going to meet an awful lot of already existing partners and champions. So that would be my advice for the start of how to engage partners in this work.
Excellent, thank you. We also have another question from the audience, and why don't we start with Deborah Lochner-Doyle. The question is, what can the state do if they do not have a dedicated Office of Genetics or Genomics?
Well, I think every state department of health does have some public health genetics. As Mueen said, everybody has newborn screening. And in a lot of states, well, I know several years ago, the Maternal Child Health Bureau asked every state to identify a state genetics coordinator. Whether or not the state still has somebody designated as a state genetics coordinator, it's hard to say, but there is a Coalition of State Genetics Coordinators website, and they do list somebody for every state. So that might be one place to kind of get started. That should be the person who sort of knows what's happening in the world of public health genetics in your state.
Okay, great. Any other questions or any other responses from anyone else on the panel?
James, this is Bev. I would just suggest perhaps also talking to folks within the Department of Public Health in the chronic disease areas, because many of them are starting to have an increased appreciation for the impact of heredity on the condition, that though they might have a dedicated program, certainly the cancer programs, diabetes, asthma, and so on and so forth. I find that many more of them are becoming aware. And so I think that would be a good set of folks to engage as well.
Okay, great. One of the questions we asked for was a clarification to Deb Lochner-Doyle. What was the website again that you just cited for all states?
It's the Coalition of State Genetic Coordinators.
Okay,
but I agree with Beverly very much that a lot of the chronic disease programs, particularly the breast, cervical, colon health programs, are really, and the heart health programs are really becoming much more involved in public health genetics. And it's another great place to start.
Yes.
Great. I have another question for Deb Lochner-Doyle, which is, have you approached biopharma companies such as Amgen, which has a presence in Washington State and has an emphasis on genetic approaches to finding new treatments, or is working with private organizations not something you think is advisable?
I have not approached private, not because I can't or wouldn't be willing to work with them. It just hadn't occurred to me, so thank you very much for that idea.
Okay, excellent. Next question, should be the role of county public health departments in these initiatives? And this one is open for anyone on the panel.
This is James. This is Bev from Connecticut. We in our state would refer to them as local departments of health, but I think it's kind of a similar term. I think it's instrumental in helping getting, in particular, the education materials that both Michigan showcased in the video, as well as the cover of one that was showcased in one of my slides. I think that they frequently have programs for local, let's say, primary care providers, or might have a family health history awareness day. So having them have access to the educational materials to be one more champion at the local level of getting the word out as close to the point of early patient contact as possible. I think they're really key.
Okay, excellent. We are actually out of time, but we have actually a lot of questions coming in. We're going to ask 2 more questions, but if you send in your questions, I will send those out to the speakers on the call, even if we don't have time to get to them today. So one of those 2 questions is, have any of your projects focused on racial and ethnic cancer disparities in addition to genetics?
This is Deb in Michigan, and something we hadn't talked about in the video, which that person can please feel free to email me and I can give them a lot more information about this, was funded through CDC's Prevention Research Center, and we've looked at, here in Michigan, 3,000 young breast cancer survivors, of which half were African American. And we've identified up to 2 of their first-degree relatives to give them information about the importance of genetic services and the importance of earlier and more frequent screening, such as mammograms. So we have done quite a bit in that realm with cancer. Also, I should also state that the largest health disparities that we've ever found here with all the work we've done in Michigan is in regards to something very different, but somewhat inside the realm of the familial hypercholesterolemia, and it's sudden cardiac death of the young. We find significant health disparities, especially with African American males, with the work we've done. So if anyone would like more information about those health disparity projects that we've worked on, please feel free to contact Deb Ducat.
And this is Jan Lowry, just in response to that. Our project did not specifically focus on those populations, but I will say using the registry sort of provides an opportunity to have broad reach across the state. So, assuring that your materials are culturally sensitive and also sensitive to the fact that people don't all live in urban areas, right? There's going to be some barriers to those living in the rural areas. But again, using the registry provides broad access to all those patients.
James, if I could add one thing that's related, that through some of our behavioral risk factor analysis, we had run questions on awareness of collection and utilization of family health history of individuals, collecting it and sharing it with their primary care providers, and greater than the health disparity among and across racial groups, it was a socioeconomic issue. So I don't think we can forget that when we're talking about access to preventive services, either the socioeconomic issues.
Okay, great. And then the final question, for those programs who have engaged in primary care physician education on BRCA and Lynch, have you seen an increased uptake in genetic testing in your population?
This is Bev. Others may want to join in. Interestingly enough, in the conversations with our cancer genetic counselors that have worked with us on this project, I think the biggest impact in the last year, I have to say, was all of the media coverage of in the popular media. I know that they had a huge increase at that time. Correspondingly, our project was going on at the same time, so it was a little bit hard to separate out the two. But they did have a big increase over this last year.
Great, thank you. Any other comments on that question? Okay, well with that, I want to thank all of our speakers. We packed an amazingly large amount of information into the hour webinar. I also want to give special thanks to the Genomics Forum working group that helped put together this webinar, especially Toby Citrin and Nicole Exey. At this point, we will conclude. We'll send any additional questions to our speakers, so feel free to send them our way. In addition, we're sending out to all of you right now a link to a page on the Genetic Alliance website where you can find other videos and resources, including CDC's toolkit that they talked about, as well as an interview with many of the people on the phone today in the States, a Q&A that was led by Sharon Terry, President and CEO of Genetic Alliance. Thank you so much to everyone for joining us today. And if you liked the webinar, please join us for future webinars and let people know about the archived videos to help share some of this information to a broader audience. Thank you so much.